Thank you for joining our webinar. On behalf of BioHorizons Camlog, I would like to welcome you to this event. Let me please introduce you to Dr. Markus Beschnidt. He will hold this presentation today with the title Conelog Screw Line, Advantageous Indication at Bone Level. Markus, can you please start your presentation?
I welcome you wherever you are on this planet. It's a great honor and pleasure for me to discuss and share some thoughts concerning implant abutment connections. This lecture is called Conelog Screw Line and Advantages. But first of all, let's talk about implant abutment connections. The visible link to the aesthetic zone is the soft tissue. And as you see on these pictures, you might easily detect where is the implant, because you see sometimes a long tooth, sometimes pink porcelain, sometimes you see an abutment. And the visible link to the aesthetic zone means you should not see where the implant is. And the hotspot we should discuss is the hotspot between bone and soft tissue margin. And there is a difference between the tooth and the implant. And this hotspot I'd like to discuss with you in the next 60 minutes. So on the tooth side, we have a very thin bundle bone, which is living and is strongly adhered to the root surface. On the tooth side, we have periodontal fibers between root surface and living bone. And these allow functional mobility. And we have a supracrestal gingival architecture, which is well organized due to 9 different collagen fibers. Looking on the other side to the implant, we know that the bony tissue around the implant needs to be thicker compared to the tooth. We know also that there is no mobility. We have a dynamic bony interaction between implant surface, and it does not matter which kind of material we have, if it's titanium or zirconia. There is an interaction. And finally, in any implant case, we don't have the same architecture, we have scar tissue. And this scar tissue, ladies and gentlemen, starts with tooth extraction. So this means in any implant case, we have scar tissue around implants. Looking at the implant abutment interaction or connection, I'd like to divide between facts and fiction. The focus is not only the hotspot. The focus is, of course, on the implant side, the inner cavity. We know that the inner cavities of implants also serve as reservoir for bacteria. It's the implant neck design. How is the design of the implant shoulder? And of course, it's the position of the implant shoulder. Is it supracrestally, so like a tissue level implant? Is it epicrestally, like a tissue, a bone level implant? Or is it beyond the bony margin? And on the abutment side, also there are some focuses we should discuss. It's the prosthetic connection. How should the prosthetic connection look like compared to the soft tissue and hard tissue, or in relation to soft and hard tissue? Which kind of abutment material do we need? Is platform switching the link to high-end aesthetics or not? Which kind of screw connection? And of course, the abutment itself has cavities. So today we only can focus on this kind of area concerning dimension and the kind of prosthetic connection. Looking at the hard tissue implant interaction gives us the information what happens after uncovering an implant. So we know from the literature, in any implant installation case, we have a loss of buccal bundle bone. So this means if we place an implant, we should think about placing some bone substitute in front of the implant to keep minimum 2 millimeters of thickness around. So this brings me to the thickness around, bony thickness around implant. On the buccal side, we need 2 millimeters for aesthetic appearance. Between implant and tooth, we need a distance of 1.5, and between two implants, roughly 3 millimeters. Because of new implant designs, these 3 millimeters start to become 2 millimeters. And later on, I'm going to tell you why. Placing the machined neck of an implant below the alveolar crest may lead to bone loss. So now that's the next thing we should think about, the implant design of the neck. Do we need a machined neck or do we need a rough neck? And the 3D bone implant relationship after loading. This is the biology. What happens because of biological reactions? Looking at these 4 different kinds of implant connections, you see this is a conical connection. This is, I think, one of the largest platform switchings on the market. You see a very large implant and a very tiny implant abutment connection with a large platform switching, but although we have this, we might have a bony resorption. So let's talk about and discuss if platform switching alone is the miracle. Because then look at the other picture here. We don't have any platform switching and we have no bony resorption. And here we have a conical connection, or it was called conical connection. And we have a bony resorption here. So conical connection alone, is this the miracle? We don't know exactly. And finally, look at the one-piece implant. This is an all zirconia one-piece implant, but although there is no gap between abutment and implant, we have a bony resorption here. What happens on the soft tissue side? Looking at the soft tissue reactions after abutment assembly. We know from the literature that we are going to have a gingival recession of 1 millimeter after loading. This we are going to have due to a kind of establishment of a scar tissue. And scar has the tendency to shrink. And this shrinkage brings 1 millimeter of gingival recession. We know also that after placement of the final crown, we have a kind of a papilla growth. We have to know this is not a real papilla. It is a kind of a scar tissue, but it looks like a papilla. The abutment material plays an important role. Also, this is well known today that titanium, zirconia, and alumina abutments have a soft tissue collaboration. We don't really know if it is attachment or if it is a kind of a growing together. We don't know exactly. We know that the soft tissue stays more in place to zirconia and titanium than to gold alloys, dental porcelains, or even resin materials. And the frequency of the abutment changes or abutment shifts has an influence. If you only shift the abutment 2 to 3 times, there might not be any soft tissue reaction. If you do it quite more frequent, again, we have a soft tissue shrinkage up to 1.5 millimeter, which is in the aesthetic zone quite a lot. And the repeated screw tightening leads again to bacterial leakage into the implant surface on the inner side. And if we have bacteria in the implant, we have a bacterial growth in the implant, and this bacteria later on may come out again. So what are the main questions which we are facing today? Which is the best implant abutment connection? What are the main problems of two-piece implants? What is the effort of platform switching? Is conical connection really superior to butt joint connection? And finally, what is the main difficulty in using any conical connection? So let's start, which is the best implant abutment connection. Look at these totally different kinds of connections. Behind all these connections, you see different strategies of just getting connected between implant and abutment. And we can just divide into two kinds of connections, internal and external connections. So, what are the main problems of two-piece connections? Points of an implant abutment connection. There are 3 weak points. The first weak point is the screw itself. We know that due to bite forces or loadings, we might have screw loosenings or screw fractures. We have gaps and cavities. Marginal gaps serve as micro gaps, and the internal surface of an implant serves as a macro space for bacteria. And we have these movements, the micro movements, which are flexural and rotational forces, and we will see where are the forces higher compared to the implant abutment connections. And the macro movements, which means tightening and untightening of abutments. So you see, the screws serve a lot of problems. They might fracture, and the more screws we have, the more problems we might end up. And I'd like to show you a very, very old case of mine. This patient came in, the implants were placed many years ago. I didn't do implants so far when I got this case, and I only had to treat the prosthetics. And this was done with a bar and with horizontal screwed on bridges. You see, it looks very nice, and it was nicely done by the dental technician. But looking at the number of screws I had to use, this is horrible for me. You see, it is more than only 6 screws. It's 1, 2, 3. It is up to 10 screws. And you know, every screw gives you a space. And the space also between abutment or bar and crown is a gap. And within that gap, you might end up with bacteria. So screwing on this bridge in the end looks very nice, but we have to know that in all these screw channels, we, in the end of the day, have bacteria. The gaps and cavities means the presence of a gap is responsible for inflammation if the gap is open to the oral cavity. The micro gap might only be 10 microns, but the size of bacteria is only 0.1 micron. And the endotoxins, which are responsible for infections, are only some kilodaltons. And finally, here you see that gap, and if you look at this X-ray, you see we have 2 gaps. We have the gap between bridge and abutment, and we have the gap between implant and abutment. And finally, the movements. The more movable the implant abutment connection is, the more instability and the more rotational instability and flexural instability we have in the end. So this can lead to damage of implant abutment device, or in the end also it might damage the implant itself. Let's have a look at the 3 different implant abutment connections. The one-piece implant. The one-piece implant from the first glance looks easy and promising. So the advantages are: we have no gap, of course. There is no leakage. No micro movements. The biologic width is the crown margin. We have high-end aesthetics because we can use all ceramic materials. And we have superior mechanical properties. We don't have a screw channel. And finally, even in narrow spaces, we can use very tiny implants. So this makes the full treatment very logical and simple. But on the other side, the disadvantages. The implant placement is much more sophisticated because once you place the implant, it's very difficult to correct the axis or even the depth of your crown margin. It's difficult to modify after osseointegration the crown margin because you have to grind an osseointegrated implant. You are not allowed to use closed healing because you already have an abutment inside. It's much more sophisticated if you need augmentation. And finally, we don't have enough long-term results, especially on the survival rates of all ceramic materials. So let's have a look at the 2 major connections, butt joint and then the conical connection. This is a butt joint connection. It's one of the oldest. It is an external hex connection. This external hex was not built for prosthetic connection. We have to know that once it was designed, this kind of hexagon, I go back, this kind of hexagon was built only to screw in the implant. So this one was first of all just a device to put the implant into the bone. Today we know that the external hex has more problems than advantages. So this was the change to the internal connection, and this is one of the most precise internal connections with anti-rotational elements. An internal connection has much more depth. Here you see the tube-in-tube connection, which gives a lot of stability on one side and a very, very tiny open space to the oral cavity. The precision fit you can see here. The production of an implant and of the abutment can be divided into turning and milling the surface. And the more the surface is milled, the more inconvenience we have with not fitting surfaces. The turned surface gives you much more precision. If you compare now internal connections, you can easily see that this connection has a higher misfit compared to this connection. So not only having a kind of connection is the guarantee for a stable implant abutment connection, it is only a kind of a description. Now let's have a look at the platform switching. Why do we need platform switching? It is the decrease of peri-implant crestal bone loss. And for a long time, we didn't really know if this is functioning and how much of this platform switching is necessary. So the possible effects of platform switching are, on the positive side, we have more crestal bone. We have more soft tissue around abutments because the abutment is more tiny. We can allow narrow implant distances because we just lateralize the gap. We can use wider implants in extraction sockets, which gives us more primary stability, and we can come out with a more tiny abutment. And we might use more shorter implants. On the negative side, the mechanical stability of the implant-abutment connection of platform-switched abutments is less compared to butt joints with the same size. If you use all ceramic abutments, at the moment we should use metal internal surfaces because of stability. So we need a combination of metal and zirconia. We need more precision in implant placement because the angles are less correctable because of platform switching. The biomechanics at bone level allow a narrow implant on one side, but on the other side, the stress distribution in narrow implants is more given to the bone. Look at this. With a Camlog system, you have the liberty of choice using standard prosthetics and platform switching. Let's have a look at the platform switching. This is a case from 2007. This lady was suffering a cancer and her oncologist told her to take out every root canal treated tooth. Here you see the root canal treated tooth. We took it out. In 2007, I measured the socket and I placed a 6mm screw line. Of course, I have to admit, today I would place rather a 5 or 4.3mm. But that time, we didn't have any platform switching implant. We only had the possibility to use a 6mm implant and a 5mm impression post, which gave us a platform switching of 0.5mm around. So we did the impression directly after implant placement. Then I ground off the junctional epithelium. I did a pouch preparation to the buccal site. I took off a combined graft from the hard palate and I closed the socket. During the healing time, the dental technician produced a platform switched final zirconia abutment and a long-term provisional. After 4 months, we did a very tiny uncovering. I placed the final abutment with the platform switching on the Camlog, and this is the long-term provisional on the right side. After 12 months of healing, you see we still have more soft tissue compared to the other side. So we could do the final crown with a little more volume on the buccal side here. We did a final impression with the transfer cap. I didn't take out the platform switched abutment anymore. And here you see, this is 1 year after healing of the implant. The final abutment I never took out, and this now is the final crown. But let's have a look at the long-term result. This is how we started and how we ended up after 1 year. This is the 2-year control. This is after 4 years. 5. 6-year control. No recession defect. After 7 years, you see the soft tissue and the hard tissue quite in a stable position. And over the years, we didn't find any additional recession defect. So with the Camlog, you already have the chance to choose between the butt joint same size and the butt joint with platform switching. The indication of the platform switching is the miracle. We know that in some reasons, for instance, the butt joint with the same size makes sense. And the more you come to the aesthetic zone, the deeper you place the implant, because you want to have a nice soft tissue emergence profile. This means using the tissue level implant in the posterior region gives you the possibility to end up with a large crown like a molar, also in a tiny implant. If you go more for the aesthetic zone, you should place the implant slightly deeper to the bone level. And if you need the highest soft tissue and a large change in emergence profile, look here. Here we have the emergence profile of the soft tissue, and this is the diameter of the implant. And if you have to change this height, you need more space in soft tissue. Later on, more on that topic. So the platform switch of Camlog allows you already to gain soft and hard tissue. By using the 6 mm Camlog, you can use the 5 mm abutment. By using the 5 mm, you might use a platform switched abutment, and you get a platform switching of minimum, you will see 0.3 millimeters platform switching. But we don't exactly know, is this enough or do we need more? So the scientific facts of platform switching. Is this the miracle? We know with platform switching we have less biomechanical stress to the bone, but we have a higher mechanical stress of the abutment complex. There is no statistical significance concerning implant survival. We have a gain in soft tissue stability with platform switching. There is no difference of papilla, even if you put the implants closer than 3 mm. So this is one of the most important parts of today. With the platform switching, you also might use implants only with 2 mm in distance. The platform switching dimension seems to be inverse proportional to the marginal bone level, which means the higher the platform switching, the better the bony stability. EP or subcrestal implant neck reduces the marginal bone level, especially if you use platform switching. And if you use platform switching of more than 4.5 mm, you will see that the bone stays more stable. Now let's have a look at the conical connection. And now we are moving to the Conelog. So not every connection which has a cone is a conical connection. Be aware of implant systems which look conical, but they don't have really a conical connection. If the cone has not the right conicity and depth, it is not a conical connection. It's only a simple cone. This is a conical connection. Why? Because we have a certain depth, and the stability of this implant only comes from the cone. The disadvantage of this implant is we don't have an anti-rotational element. We don't have a positioning index. So the cone, once set with an abutment, should not be removed anymore. This makes prosthetics a little more complicated. So this is a connection with an anti-rotational element. This also is a conical connection with a positioning index. So here, and this is the Conelog, here two advantages are put together. The one is the conical connection. We have a conical connection from here to here. But we also have a so-called positioning index. It's not an anti-rotational index. It's a positioning index for easy prosthetics. So this is the combination of a conical connection, which is quite stable, but with the easiness of the Camlog, which means you have 3 different predefined positioning indexes where you can place the abutment, and this is very easy for your dental technician. Now, looking at the Conelog means looking not only at a conical connection, then rather more looking at a concept. It's more than a simple cone. It's a kind of putting the force distribution more even to the bone. And we have a built-in platform switching, which is quite larger compared to other systems, including a positioning index. It is not an anti-rotational element. You don't need an anti-rotational element so far because the conical connection itself serves as anti-rotation because of the conical forces. So this is now the 3 cams and the cone, and you see you can turn now and then the cone is going to fit. Once again, the screw comes in. So if you bring in the abutment, it's very easy. You just bring in the abutment, you turn it. Now we have the positioning index, and now the cone is going to fit. So there are 2 types of platform switching now. The Camlog platform switch and the Conelog platform switch. The Camlog platform switch is not available for the 3.3. And you now see this is the PS for the Camlog. It's up to 0.8 if you use the 5 millimeter for the 6 or the PS5 for the 6. On the other hand, you only have 0.3 millimeters of conical platform switching. Let's have a look at one case where we did this, and you see this case is almost 15 years old. This is a lady. We had to take out both central incisors because of root canal treatments and failures. So to make a long story short, we started with the right incisor, and 2004, no one was talking about platform switching, I have to admit. So we placed a 6 millimeter screw line, and although it was 6 millimeter, I had a gap on the buccal side, which I filled with a bone substitute. I did a 5 millimeter impression taking. So here I have, from a 6 millimeter to a 5, I have got 0.5 platform switching. We did a connective tissue graft, the final abutment, a long-term provisional. After 2 days, I place the final abutment, and you see how nicely the soft tissue grows on the surface. After 12 months, we produce the final crown. 2 years later, she got problems with the left central. So we took out the left central. I placed a 5 millimeter implant. I did the impression taking, and we did a so-called individualized, customized platform switching, because again, 2006, no one was talking about commercial available platform switching. And again, after 2 days, I placed the final platform switched abutment, and the long-term provisional. That was 1 week post-op. Now we have 2 neighboring implants, both with platform switching butt joint. This is 9 months later. Now we cement the final crown, and you see, even during cementation, you might lose the central papilla, but you have to know this one, if you don't touch it anymore, comes back. And here you see the long-term result. Over 5 and 2 years, you see that this was 0.5 millimeter platform switch. This is 0.2 millimeter platform switch. And now let's have a look over years. What happens? Even to the scar papilla, 6 years to 3 years, 7 to 4, 9 to 6, 10 to 7. Look at the bone. The platform switching after 11 years. No bony resorption. 11 to 8, 12 to 9, 13 to 10 years, 14 to 11. And after 14 years, look at the bony level. So the platform switching, yes, makes sense. And this is the situation after 15 years now. We still have the bony peak. And if you see, this is 6 millimeter implant and 5 millimeter implant. We only have 2 millimeters in between. What about the Conelog? Here we have the platform switching starting from from the 3.3 with 0.25. And then we have platform switching up to the 5. We don't have a 6 millimeter implant here. Looking at the case, here we have a lady with a bony resorption at the lateral. So with the platform switching and the Conelog, we try to keep bone, but at the moment we don't have bone. So what did we do? We started to extrude the root with an adhesive bridge and a band of rubber. So we did root canal, we shortened the root, and we placed this bridge with a hook inside just to pull out the root now. Here you see the rubber band from the orthodontic treatment. And this is after 4 months. So again, after 4 months, we shortened the root. Here you see this is after 4 months. We shortened the root, we put the hook again, and we wait additional 2 months. Now we have 6 months of extrusion in total. Now you see what happened. We could get bone, but it's a very soft bone, it's a very fresh bone. Now we have to wait a certain time, and during this we did the implant planning. And now we take out the root. We check the bone. Yes, we have enough bone on the buccal site. We do now the guided implant placement. And here we place a 3.8 millimeter Conelog now. So this is, I go back, so this is the 3.8 Conelog placed through the guide. Because we have, of course, flapless surgery, we don't see the bone. Now we place an impression post, and we do immediately a transfer impression with this splint. Today, of course, you can do this with optical devices with an intraoral camera. So now we raise a split thickness flap to fill the gap between abutment and socket. Now I place a 2 millimeter healing cap. I augment around the healing cap, around the gingival healing abutment, so I can get more height of hard tissue around the implant. And finally, I take off a connective tissue graft from the hard palate, which is now sutured into the buccal and crestal site. So this is how we end it. And after 3 months, we uncover and we place the final abutment and the long-term provisional. And now look, after 9 months, we have a nice stable situation, although we did extrusion and augmentation. And this is the final crown. Look at the platform switching. Look at the situation. Where has the bone been and where is the bone now? And with the conical connection, we can keep the bone up to this area without any resorption. And this is the 2.5-year control. So with the Conelog, the platform switching is higher, and for this, the bony stability is better. The limitation of platform switching. Why do we have limits? If you place an implant and an abutment and you have a certain crown dimension, this would fit nicely. If you now place a platform switched implant abutment connection, you might end up with a hygienic problem. The higher the implant position and the wider the crown. So if you now would place this crown with the abutment and the platform switching, you might end up with a hygienic problem. You can get rid of that problem if you need a large crown by placing a wider implant or by placing the implant more down to the bone, or in some cases, for instance, beyond bone if you want to use the platform switching. So this means, in the end of the day, using a switching of the platform, we should use a switching of implant height. So the butt joint implant should be placed more to soft tissue and bone, and the conical connection should be placed closer to bone or beyond the bone. So if we now compare Camlog with Conelog, you see the difference. If you need a certain dimension for your crown and you have the possibility of a wider implant, and this is a 6 millimeter, then you should place the implant maximum 0.4 millimeters above the bone. If you use a conical connection and you need to use a large crown because it's a molar, you might end up with a hygienic problem in this area. So this implant should be placed deeper. Let's have a look at the implant shoulder beyond bone level. So what we want to have is that the implant shoulder in a Conelog implant is beyond bony level. And we want to keep the bone, especially on the buccal side. If you look at this case, you see on the buccal side 2 millimeter bone in thickness minimum, and we have bone above the implant shoulder, although it is a premolar. We also have this, if you look beside an implant, between implant and tooth, or even between two implants, this is a Conelog, and you see that the bone is close to the abutment here. I'd like to show you a case how we do this. 2014, I met a patient who had extraction several months earlier, and after extraction we had this bony resorption. So on the other side he already had an implant, but here we have a bony resorption, so we knew we lost the bundle bone, and normally the bone would have looked like this. This was how it looked like before, and now we have the resorption of this bundle bone. So we did prosthetically driven implant placement without a guide. Of course, we didn't want to load immediately. So now we place the implant into the right depth, not beyond bone, but we need bone above the implant shoulder. You see that there is uncovered implant surface of this Conelog. What did we do? Now we did immediate impression taking again. And now we place a gingival healing abutment which has a height of 2 millimeters. Here you see, this is the healing abutment. And this healing abutment should be covered with bone or with a bone substitute, much better. I think I have got the same problem again with my... now, okay. Now we place the membrane. After that we place a bone substitute, and now I do the augmentation up to the healing abutment. You see, this is only a bone substitute, and I augment around the healing abutment, so I do the augmentation above bone level of the implant. We close with a membrane and with a connective tissue graft. So this is now directly after closing. You see how we could gain thickness and height. So here you see on the X-ray the position of the implant shoulder and the position of the bone peaks. And of course we know that this is a height of 2 millimeters. After the impression was made, the model was made, and then we produced the final abutment and the long-term provisional. Healing period was 6 months, and now we do the uncovering with a simple punching. We take out the abutment. We try in the all-ceramic final abutment, and the crown, after checking, is just pushed in with chlorhexidine gel. So now this is the long-term provisional on the final abutment. And now we wait. And here again you see the height of the bone. So the implant still is beyond bony level. The luting base of the abutment is about 1 millimeter. At the moment we still have bony contact on implant shoulder. After 4 months it looked like this, and after 6 months we just gave a little more contour to the labial side to shape the soft tissue. At 9 months, we did impression taking with a transfer cap, and this is the final crown. Again, look at the hard tissue. You see, after 12 months, we still have bone on the implant shoulder. In close, I would not say contact, but in close neighborship to abutment. So if now the Conelog implant is placed beyond bone, there is no gap for bacteria because there is no contact to the oral cavity. Here is how we started and how we now ended up. That's the 2-year post-prosto result and 3 years of loading. And here you see after 2.5 years, we took again an X-ray and look at the bone 2.5 years after loading. We still have the bone above implant shoulder. There is no bony resorption at all. And that's the 5-year loading result. So yes, it makes sense to put the Conelog beyond bone. So, but what is the main difficulty using any conical connection? Why is the Conelog not an implant for every beginner, especially for the prosthodontists? It is called the vertical misfit. Looking at the butt joint connection, this is the Camlog and this is the Conelog. We know with the butt joint connection we have a well-defined stop at implant abutment connection. If you place the conical connection, you in every case, even if you produce the implant and the abutment on the highest level, you have a so-called vertical misfit. If you now screw in the conical connection, you have forces to the implant because of the conical connection here. But this ends up with a vertical misfit. How can we get rid of this vertical misfit between lab and clinical site? And it was done with the healing abutment and the transfer posts without a conical connection. So the transfer post of the Conelog is not conical. It is a butt joint. And this gives you the stability of the butt joint connection and the precision of the butt joint connection during the transfer to the lab, although we have a conical connection finally. Here you see, this is the conical connection of the insertion post, and the impression post doesn't have any cone. On the other hand, once you placed the cone, it is very stable. And you will see using the Conelog makes it difficult if you want to remove the abutment anymore, because the stability, because of the cone and the conical fitting is such high that you normally manually do not take out the abutment anymore. So if you need to take out the abutment, you use this special screwdriver which pushes out the abutment by just screwing in the screwdriver. It pushes out. And then you can easily take out both abutment and screwdriver. So the scientific effects about implant abutment connections. The design of an implant abutment connection is a high relevance for the stability of soft and hard tissues. All two-piece implants show gaps, and those gaps serve as bacterial reservoir, especially when your implant shoulder is open to the oral cavity. The microbiological colonization of the gap may result in infection, and infection results in resorption. The gap cannot be eliminated totally. The conical connection seems to be mechanically more stable compared to the butt joint. And this is important. If you now place a very stable conical connection beyond bony level, it looks and serves like a one-piece implant. The conical implant abutment connections show higher vertical deviations, of course, and this makes it a little more difficult in the prosthetic workflow. The original tube-in-tube connection of the Camlog has a very high mechanical stability because of its tube length. In the conical connection, the rotational stability is secured by the cone. In the Camlog system, it is secured by the cams. Under static and dynamic loads, all two-piece implants show increased gap formation over time. The one-piece implant cannot preserve marginal bone and hard soft tissue resorptions. So this says at the moment the conical connection is an implant especially for the aesthetic use. I'd like to give you my kind of choice between when do you use the Camlog and when do you use the Conelog. The Camlog philosophy is like this. If you need to combine implants with a large bar like you see here, or with a bar with close standing implants, or as you see in the lower jaw, here the Camlog is easy in use for the prosthodontist. It's a simple design, easy prosthetics. I'd like to show you finally how we do this in immediate loading. Here you see the upper jaw of a lady where we want to place immediate implants and immediate loading. So we took out the upper dentition, we did perio treatment to the lower. This is on 3 temporary implants, an immediate prosthesis, and now we did the planning of 6 strategic implants. You see, everything was done digitally. We have 2 angulated implants more to the palatal, so we need angulated abutments here. And with this, we produce a drilling guide. And now we produce the long-term provisional. And this is what I get to surgery. And now we place immediately 6 implants. And if you use the Camlog implants now, you can easily connect them by luting the bridge intraorally, and it fits again after taking out and screwing in. So this is the Camlog philosophy. At 1 year, you take off the bridge and you can just do the impression for the next one. The Conelog philosophy is more aesthetic driven. This means we have to place the implant deeper, even if we want to restore a molar. So this is a 5mm implant, and if you want to restore a molar, the implant should be placed beyond the bone. So this is 2 months after surgery and 1 day after placing the crown. And you see the emergence profile is easily made with this height of emergence profile and distance between crown and implant shoulder. And even after 3 years, we still have bone at the edge of the implant shoulder here, because the gap is placed in an area where it is not open to the oral cavity. So the Conelog strategy is to place the implant, in any case, subgingival or even more subcrestal. It's the high-end aesthetics. You have a larger platform switching than the butt joint platform switching, which means more soft tissue thickness, closer implant distances, large implant diameter but tiny abutment design. The prosthetics, on the other hand, is a little more sophisticated. You have higher forces and the abutment fit is more difficult to control. Look at this X-ray. Here we have a wide body healing abutment, but at the moment, screwing it in, you can't control if it gets in contact to the bone. So sometimes you need to take an X-ray to find the right position, like you see in the lower picture. Let's have a look at one of the final cases. How I use the Conelog, especially in the aesthetic zone. 2016, this lady presented with some root canal treated teeth. Of course, she already had some bony resorption, but she wanted to keep the teeth. So we said this is a temporary treatment. And after 2 additional years, she had resorptions, as you see here, and the anterior teeth had mobility grade 3. So we decided to place 2 implants and a bridge. This implant and this as an implant, and we wanted to do this with a full digital workflow. So we took a cone beam CT. We just measured if it's possible to do immediate loading. And then we planned implant positioning and, of course, long-term provisional. So this was the digital planning of the long-term provisional. And this is what I got before treatment. Because I didn't know if we could keep the canine, the long-term provisional just had a cantilever with a canine. If I don't need it, I just can cut it off here. And I tell you, I didn't need it, so I cut it off later on. So then we started with extraction. We removed the junctional epithelium. And now we do the guided implant placement of 2 Conelog implants. You see the positioning index is marked on the black buccal side. Now we place both implants, and with the marking exactly on the buccal side, like the guide looks like, as you see here. This is important if you do immediate loading with the final abutments. So now we place both implants, we take off the guide, we put both abutments, and we try in the long-term provisional. Now we do the socket preservation in the middle, hard and soft tissue augmentation to the sockets, and of course a connective tissue graft in the pontic site. Finally, we place, this is the connective tissue for the pontic. Finally, we place the zirconia abutments now with hand force. And we bring in the bridge only with the chlorhexidine gel. No cement needed for the first days, because I don't want to use cement is the reason because of the bleeding wound. Now you see the Conelog is placed beyond bony level. This is the Camlog which was placed 15 years earlier. The Conelog, for aesthetic reason, is placed here. The abutment is not taken out anymore. So this is the 7 days control, the bridge, and after 6 months we did the final impression taking with transfer caps. We didn't screw out the abutment anymore, which means we have a nicely healed wound around the abutment, and now the abutment implant interface beyond bony level serves as a one-piece implant. We don't have a gap open to the oral cavity. And this is the final all-ceramic bridge. Again, look at the bony resorption. We have, of course, a bony change, but here we have first bone contact. Here we have bone contact. Again, here we have bone contact. And this is the 2 years control. So, to conclude finally, in my personal opinion, the Camlog butt joint connection is the classical all-rounder. You can use it with platform switching, without platform switching. It's very easy for the prosthodontist and also for the dental technician. The Camlog system still has its place in implantology. But the Conelog joint is, in my eyes, an aesthetic specialist. If you have a thin gingival biotype, for instance, if you have less bone, if you want to place the implant deeper, you might use the Conelog. It's a stable, very nice connection, but it needs a lot of knowledge. So finally, the choice is up to you. I'd like to finish with a personal suggestion. If you are now keen on how to do this, or if you'd like to learn hard and soft tissue more in detail, there is a completely new approach to surgical and anatomic courses for dentists and surgeons. It's called the course. And the course is a 4-day, I say it is an experience for you, because it's very, very intense learning procedure. It is a 4-day experience in a nice location. It's Vienna, Austria. We have this education in the Hotel Regina at close to the center of Vienna and at the Anatomical Institute. And here you see it, the Hotel Regina is a very nice old Vienna hotel. And all hands-on parts we do at the prestigious Anatomic Institute, which has a dissection room especially for these courses. And here is the program. The first day we start at the hotel with theoretical education. You learn things about soft and hard tissue, about biology, equipment, and microsurgical principles. Day 2, we start at the Anatomic Institute. In the morning, you get a human specimen. And we are going to show you step-by-step flap design suturing techniques, only to soft tissue. In the afternoon, we do only hard tissue augmentations. Again, we start with basics up to high end. Day 3, you get a new specimen. And then we start with the so-called bespoke treatments. You tell us what you want to do. You tell us the cases you routinely have in clinic or you want to do after the course. And you can train this specific treatment at a human specimen. In the morning, we do this to the soft tissue, and in the afternoon, we do this to the hard tissue. Day 4 is again at the hotel, and we are talking about risk management, patient education, and finally, the cases you want to see. So here it is, the dissection room. It's a large room made for up to 20 participants, and you get a lot of equipment to do surgery. Not only knives and sutures, you get a lot of things to do hard tissue augmentation, membranes, soft tissue augmentations, you get injection materials. The course is led by 2 directors. One of them is my dear friend Rudi Seemann. He's one, in my eyes, of the best orofacial and maxillofacial surgeons, and he knows everything about anatomy. And by me, I try to teach you in microsurgery and in slightly touching. The theory is just neighbored by the hands-on, and you see, before we do surgery, we start to explain everything on the whiteboard, and then we do it live for you after explanation, and then you start to do it by yourself. Here you see the international groups. It's maximum 18 to 20 people. If you come only from one country, you may bring your own translator, and you have your private group finally. The group of 2020 already is sold out and overbooked. So probably you just ask for 21, and maybe I see you not only on the digital way. I hope to see you soon. Stay healthy, and in those weird times, I only can say, live long and prosper. See you in the real world. Bye-bye. That was my part today.
Thank you very much, Dr. Beschnidt, for this great presentation. Just to follow up some information, so you can find this webinar on BioHorizonsCamlog.com. For courses, please go to camlog.com or BioHorizons.com. Thank you very much again. Have a good time and see you probably at the course. Goodbye.